Good afternoon, everyone. You are very welcome to the HSE Health Regions webinar series. Today's staff information and learning session is titled Balancing Stability with Change, Creating Conditions for Integration. The panel would be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC laptop screen. If you are using an iPad, you will find this feature located at the top of your screen. If you are using a mobile device, please access the Q&A feature through the three dots. Without further ado, I will now hand you over to your host, Liam Woods. Thank you.
Good afternoon and welcome to the webinar. My name is Liam Woods. I'm Director in the HSE for this change programme, and I'm joined by colleagues who I'll introduce as we go through the webinar. So I'll share some slides just to run through both in the next hour and some content myself in terms of updating where we are at the moment in the change programme. Now, the objectives of the session are to update on health region implementation, to share some reflections from lived experience of an integrated care team, and then to look at considerations for balancing stability with change while creating conditions for integration for individuals, teams and services. And there'll be a panel Q&A at the end of the session, and we will signpost resources and make them available at the end of the presentation. So just a reminder in terms of the vision, the Sláinte Care document in 2017 identified very clearly that the focus was to be on delivery of person-centred care informed by needs of people and communities, and very much also an emphasis on aligning acute and community services in the interests of patients and service users, and also coordinating closer to home. So the intent in this change is to bring decision-making closer to patients and service users, and while needing to maintain a balance of national standards, also focusing very much on local decision-making. And a strong focus on health and well-being, which has been supported by an investment in public health medicine over the last year and a half, and particularly supported by learnings post-COVID. So and there's a focus also on fairly allocating resources and accounting for those resources as allocated. The objectives in Sláinte Care are objective 1, align and integrate hospital and community resources, clarify and strengthen governance and accountability, support a population-based approach, improve the equitable, reasonable investment and balance national and regional autonomy, and also run an efficient and highly productive and transparent health and social care environment. So those objectives are coming straight out of the Sláinte Care document. They've heavily informed the thinking around the change programme and continue to do so. The map in the middle shows the 6 new regions as created by decision of government, that decisions back as far as July 2019. So in terms of what's decided to date, so the health regions, the 6 regions are identified, as you can see on that map there. There is still one board in the HSE. It's a single entity with 6 new administrative regions that are integrated. The regional health fora, which exist in law, and there are 4 of those at the moment, will become 6 based upon a legislative change which the Department of Health are overseeing. And on the 1st of October, the new integrated health areas will replace the existing CHOs, the community health organisations and hospital groups. And the operational focus will move from the centre to the regions. To a large extent, that's happened in the sense that there are no longer operational directors in the centre of the HSE. The 6 regional executive officers have taken on accountability for their regions as far back as March and April of this year. The HSE centre will still have a role in developing and overseeing standards and guidelines, and also in ensuring consistent delivery of care with a view to having strong regard to planning, enabling, performance and insurance as core functions of the retained centre. And the HSE centre and region structures have been agreed. We'll come to that now in further slides. So in summary, there will still be one HSE. There are 6 connected regions, so they're integrated geographies. Within those 6 regions, there are 20 integrated healthcare areas, and the 20 IHA managers will come into place on the 1st of October. And those 20 IHAs are made up of the 96 community health networks, which inform the whole structure. All of the boundaries, right up to the single HSE, obviously, are consistent with and don't break the boundaries of the community health networks. The vision very much in diagrammatic terms is represented by having the patient service user at the center and services in increasing complexity around the patients, but as much service at home as possible. And the services, as I'm sure some of you are aware, are seeking to deliver in that context right now. But the future is very much about supporting patients to stay well and to be at home as much as possible. Our journey as a team in terms of the work we're doing for the remainder of this year and into early next year is about publishing the maps for the integrated health areas. That'll happen in the first week of October. Standing down the community healthcare organizations and hospital groups and standing up the health regions in terms of integrated health areas, and then focusing on future design for the integration of service delivery. So the intent there very much is to focus on the kind of structures that are required underneath an IHA manager to run services effectively. And that's a significant change, and it's one that will involve really all stakeholders, unions, representative groupings, managers and service providers across the country, and voluntary entities as well as patient representative groupings. We've been engaging extensively in the work we've done to date, but we will certainly be continuing to do that. And the intent is that by March next year, 3rd of March next year, the final design for the entire system will be put into place. And I'd like to welcome Mr. Tony Canavan, Regional Executive Officer for HSE West Northwest.
Thanks, Liam. It's clear that a lot of work has been going on over the summer months and indeed into the autumn in getting ready for the rollout of the new regions. I think we're approaching another important time with the development of the integrated health areas. And particularly, I'm thinking about that period from the 1st of October through to the 3rd of March. So you might remember that our plan is that that the hospital group CEOs and the chief officers on the community side, that they will be stepping down from those roles from the 30th of September. The new IHA managers will be taking up their roles on the 1st of October, and therefore it's important that we put an interim arrangement in place so that the IHA managers can pick up those responsibilities. That interim period, that 5 months, will be really important to allow us to engage again with our staff and with service providers across the health services to really plan what the final management structure will look like. And if we use that time well, I think that come the 3rd of March, we will be in a position to roll out the final structure at that time. But 1st of October is also a really important phase for us, because those of us working in the service, we know that we're heading into probably the busiest time of the year for the health services. And so the overriding consideration has to be that we keep service users, and we keep our services and patients, we keep them safe throughout that whole period. And that we do that while we're having the discussions, having the consultation and negotiation that's required to further develop the rollout with the regions. So with that in mind, I guess the underlying principle of what we're doing now is that we're making the necessary changes, enough to keep us moving forward with this process, but also not doing so much that we disrupt or interfere with the safety of the services overall. And so from the 1st of October, we'll be seeing that the IHA managers will be in post, as will other members of the regional health area management team, like the regional clinical director. We already have the head of finance and head of HR in post. We have other key appointments made, like in public health and indeed in estates as well, that are helping to support the regions. But with the appointment of the IHA manager on the 1st of October, I think we'll see a real shift then. Our plan is that the hospital managers would report directly to the relevant IHA manager at that time. So if you take a county in my own region, for example, County Mayo, there's just one hospital, Mayo University Hospital in that region, and the manager of Mayo University Hospital will report to the IHA manager from the 1st of October. And so that's quite seamless. It's a bit more complicated on the community side, where our services are largely managed by heads of service. So, for example, a head of service for primary care, heads of service for mental health, and so on. So we do need to continue to work over the coming days to figure out exactly how that structure is going to work from the 1st of October. But essentially, the basic underlying principle of making sure that while we make the necessary changes, we don't go further than is absolutely necessary in order to keep things safe. So we work that through with stakeholders, and the hope and the intention will be that we'll have arrangements in place from the 1st of October to carry that forward. The 5 months, as I said, is a really important period of time for us because there is a lot of planning still to be done, a lot of consultation to be done with staff and staff representatives to make sure that what we arrive at from March 2025 is the best possible management structure that we can have in order to ensure that our services continue to integrate and continue to function in a way that's both effective and efficient, but also in a way that makes sense for our patients. And in that way, we'll be making the most out of the regionalisation of our health services. Thanks, Liam.
Thank you, Tony. And I'd now like to introduce Dr. Maria O'Brien to relate learnings from the Chronic Disease Management Programme.
Thanks very much, Liam. Good afternoon, everyone, and I'm delighted to be here today. My name is Maria O'Brien, and I'm the Service Improvement Lead for the Integrated Care Programme for the Prevention and Management of Chronic Disease in Ireland. The work I'm presenting here today is the work across the entire ICPCD team, which includes the NCP Respiratory, the National Clinical Programme for Diabetes, the National Heart Programme, which is all under the leadership of Dr. Sarah O'Brien, and this is the team here in the slide that you're now seeing. My role is to support the implementation of the integrated model of care for the prevention and management of chronic disease, and to do so using a servant improvement approach. And I hope this afternoon to share with you my experiences of supporting implementation of integrated care for chronic disease, and to tell you a little bit about the journey that we've all been on the team. To give you an outline of the change management approach that I've used in my role as the Service Improvement Lead, and also to outline how we've tried to create stability in the wider environment of change and reform across the HSE. I will later be joined in this conversation with two of my colleagues, Gillian O'Loughlin, who's the operational lead from the Chronic Disease Specialist team in Tallaght, who's going to share with us learning from her experiences over the past few years of operationalising one of these chronic disease specialist teams. And then Miss Liz Murphy, who's the Community Cardiac Rehab Coordinator in the CNS in the Chronic Disease Hub in Wexford. And Liz will share her experience of successfully implementing an integrated cardiology services across community and acutes there in Wexford. So firstly, I just want to set the context. What is the change that we're talking about in the Integrated Care Programme for Chronic Disease? So by way of background, Ireland's population is ageing, and we're all aware of that. It's estimated that over 1.3 million people in Ireland are living with at least one of the four major chronic diseases, namely cardiovascular disease, COPD, diabetes and asthma. And due to advances in medicine, we are now living longer, but living longer with higher levels of chronic disease. And so our health services need to adapt to meet the evolving needs of our population and to deliver person-centred care. So the objectives of the ICPCD are to maximise prevention, enable people to optimise self-management of their conditions, to support the provision of GP-led primary care, and in order to achieve all these objectives, a significant change was required in how we deliver services for chronic disease prevention and management heretofore across the Irish Health Service. So for those of you who'd like to read a little bit more about the model of care, the link will be posted shortly in the chat for you to download the document. So this is the model of care for the Integrated Care Programme for the Prevention and Management of Chronic Disease. And just, I suppose, what it places an emphasis on is prevention, early diagnosis and proactive management of chronic disease. And it's about strengthening GP-led primary care. And as you can see, the bulk of care is delivered through level 0 to 3, which is in the community. The ultimate aim of this model is to provide end-to-end care for individuals living with chronic disease and multimorbidity in the community. The integrated model of care for the prevention and management of chronic disease was funded for national rollout in 2021, and implementation is still ongoing. And the model aims to turn the previous hospital-centric model on its head and provide 5 levels of care spanning community and hospital, with a focus in community, involving all healthcare professionals and interdisciplinary working. And at the top of the pyramid is acute hospital care, which can't always be avoided, but the focus there will be on early and supported discharge where possible. The focus of the discussion today is around implementing level 2 of the model of care, which constitutes a completely new service for patients with chronic disease to be delivered in the community, and that's through our community specialist ambulatory care hubs. So we're looking at levels 2 and level 3, and currently we now have 26 of our 30 hubs operational, and they're available to support GP-led care. The chronic disease teams provide GPs with the option of referring patients to a specialist team as an additional service, whereas heretofore the only route available to specialist opinion and services was to refer patients from acute hospitals to, so this constitutes a significant change for GPs. As I said, the purpose of the teams is to provide timely and equitable access to diagnostics and specialist multidisciplinary advice in order to support the GP in providing person-centred care for patients living with more complex chronic disease and multimorbidity as close to home as possible. And these community specialist teams will also need to flex to meet local need and patient need by working together across boundaries. So working in a multidisciplinary and a multi-speciality way to deliver integrated care for people in the community. So implementing these new services also required defining new roles, including an integrated care consultant and an integrated care clinical nurse specialist and HSCP roles that would work in interdisciplinary ways across both community and acute and across specialities for cardiology, respiratory and diabetes. So in order to establish this new service in an equitable way, a multidisciplinary team was developed and funded through the Enhanced Community Care Programme across 30 locations across the country aligned to an acute hospital. These are community-based teams, 30 teams dedicated to specialist multidisciplinary chronic disease staff. And this table here on the side of the slide outlines the makeup and the construction of that particular team. As you will see, it's a multidisciplinary team intended to work in multidisciplinary approach, providing a multimorbidity approach to providing care for patients. In addition to these 30 chronic disease teams, additional posts, including 75 new integrated care consultants, have been funded and are being recruited who will work across hospital and community. And this is a very innovative approach to consultant-led care, where it's a new post working across community and acute in a 50-50 basis. In addition, nursing and health and social care professional acute posts, some of whom again will have a commitment to work across community and acutes, have been created and funded, and a significant uplift has been provided to support the delivery of direct GP access to NT-proBNP, echocardiography and spirometry testing to support GPs with direct GP access for diagnostics. One of the key things, I suppose, on these teams is the operational lead, and obviously this is a key role of which I would have engaged with in terms of supporting the change and implementation and operationalising of the integrated care teams and programme. So the key changes were movement from hospital-centric model to an integrated model of service delivery across acute and community, establishing new services, that's the 30 community specialist teams, to provide a full end-to-end pathway, and establishing new pathways and ways of working. And some of the key challenges involved in that were looking at some of the enablers, so ICT, recruitment to states was required. And from my perspective as the service improvement lead, how was I going to support the operational leads and the teams in implementing this change across the ICPCD team? So how are we going to build commitment, shared purpose, develop relationships and influence the ways of working required to implement integrated care for chronic disease? And I suppose some of the key things we needed to pay attention to were creating the conditions for change, like creating a shared purpose, stakeholder engagement and planning, communications with key stakeholders locally, and a focus on people and culture and the people and culture elements of change, which was actually a key factor to the success of the work that we've been involved in. And one of the key supports to us was the HSE guidance document, creating the conditions for change and integration. And I know some of you are already familiar with that, but the link will be posted into the chat there shortly for anybody who would like to see a little bit more in relation to it. So as part of this approach and looking at creating the conditions for change and integration, what were the key aspects that we identified as required by us to manage the change and to help create stability across the system? So I suppose the first piece was the model of care, and the existence of the model of care helped to create stability in terms of service provision by outlining a shared purpose and vision and a shared pathway of care end-to-end model to be delivered across all services and all hubs and hospitals across the country. So in order to create using that model of care, it was important to ensure that people understood the model of care, and we engaged across the clinical programs and the ICPCD program in extensive engagement across areas to make sure that people understood and were familiar with the model of care. Another, I suppose, part that was really important for us was to engagement in an ongoing engagement to create shared purpose and shared vision and to build those key critical relationships at local level. Always very conscious that while we're a centre-based integrated care team, the people on the ground are in the operational leads and obviously the teams that were put in place across the country are the people who are actually affecting and implementing the change. So how do we engage with those and build those relationships that are required between us and them to support them in their role in terms of implementing chronic disease? So we did that in a number of ways. The integrated care consultants, each of the clinical leads met regularly with the new integrated care consultants as they come on board. And the clinical programs engaged extensively across sites with site visits and with virtual meetings to develop relationships with staff across the teams and to provide ongoing clinical advice and guidance in terms of operationalising services. For me, a key person within each of those teams was the operational leads. And in terms of building those relationships, I would have had bi-monthly formal engagements with the operational lead in a structured way and informal engagement on a day-to-day to provide that support over the phone. And obviously then having a shared learning experience as well across all of the operational leads, where we would bring them together once a quarter to share the learning and ways of working that they had, I suppose, been innovated across the system. Developing an engagement plan at the very start was really important. And I suppose I spent the first 2 months traveling the country in my role to get out and meet people and see people where they were at, learn from their experiences, learn from their challenges, and learn about some of the innovations that people were implementing to try and support them overcoming the challenges of operationalizing such a large program of work. And this was a new approach because up till now, I suppose engagement had been remote and virtual, and really, I suppose, helped to copper fasten and build and embed those relationships with the operational leads and their teams and help to create that shared vision. So that was actually a critical part of managing the change and creating stability. Another way we supported the teams was through the ICPCD team, was to create a number of support resources like referral guidelines and support documents. And all of these are available freely to everybody on the HSE ECC hub. And we'll post the link into the chat there shortly for people who would like to actually look up and look at some of those materials further. And again, ongoing communication and engagement across all forums was critically important. Monthly webinars and information sessions, recordings of some of those monthly webinars are actually on the hub as well. We produce newsletters on a quarterly basis and articles on health matters, all about trying to I suppose, continue to create and maintain that shared vision and purpose across the system. So what have our key learnings been? I suppose the change in terms of delivering integrated services is a fundamental shift, and it will take time, years, not days. And some of the key learning we've had, I suppose, has been the importance of continued sustained engagement, because we're all working in an environment where there are competing and new emerging priorities all the time. And it's really important to stay relevant and make sure that the ICPCD model of care stays relevant and on the minds of those who were looking to implement the programme. The importance of aligning to the bigger context, and obviously with the current HSE reform and the health regions, it's been very important for us to stay relevant there. To maintain the shared vision and make sure that people don't forget what the shared vision is really critically important, which is all aimed towards achieving our Sláintecare vision in the end. And fostering and maintaining those relationships, particularly where you have staff moving on and people changing roles, it's critically important there to maintain those relationships as well. Engaging and networking, as I said, and it's been really important, but also supporting people's efforts and addressing people's concerns, acknowledging the challenges, supporting people to try and overcome them, and allowing exchange of knowledge and information across the system has been critical to allow people to overcome some of the challenges that they've experienced in terms of implementing the programme. And I suppose on a positive note, building up on the impact stories, sharing learning and experiences has been absolutely significantly powerful in terms of maintaining the momentum. And it's particularly important when we're talking about a long-term change such as implementing integrated care across the system. It's a marathon, not a sprint. And we do need to keep our staff engaged and motivated. And the best way to do that is by showing that this model does actually work, and it can work, where people have been successful in terms of implementing it, and continuing to share that on an ongoing basis is really important, and celebrating the success. So I hope that I set out the context for you in terms of how the ICPCD team has been supporting implementing the model of care and supporting the local areas in terms of their work in doing so. And we've tried to create some stability and through our approach to working with local areas. But I think what would be really nice now would be to hear and have a conversation with Gillian and Liz in relation to their lived experience of implementing this change. So Gillian, we might move to you firstly and to hear a little bit from you as to about your role and the change that you've been leading.
Thanks very much, Maria, and thank you for inviting me to share my experience in our hub. So as you said, I'm the operational lead for the Chronic Disease Hub in Dublin Southwest, and I'm linked to Tala University Hospital. You can see here a picture of, this is our Boot Road hub, but also some of our teams in action. So I suppose I took up this post, this exciting new role 3 years ago, and my first job was to hire the 3 consultant-led clinical specialist teams in the areas of cardiology, diabetes and respiratory. Having worked in the acute sector for all of my career as a dietitian, I was fully aware of the gaps in the services for patients in the community. And it was such a luxury to be told you can hire all the various specialist teams required. And despite the challenges in recruiting, we managed to fill 60% of our posts.
So I might just stop sharing there, Gillian, because it was really nice to see your team and to see the hub and to just visualise where everything is. I suppose, can you share a little bit with us about how the National Clinical Team has helped you in implementing the model of care?
Yeah, so as part of the integrated care programme for chronic disease, there were a number, as you mentioned already, there was a number of key support documents developed to help guide the rollout of the programmes. And these provided as such a roadmap for all of us to follow. It was like being given a recipe to bake a cake, and all you needed were the essential ingredients to go off and bake it. So regular meetings with the ops leads nationally and the NCAGL group provided a great platform to enable peer support and also share our learnings with one another. Our bi-monthly meetings with the change manager was really helpful as well. And then the clinical leads did regular webinars, which we used to hang on every word, and site visits also, which supported staff in the rollout of the service.
So I suppose, Gillian, in the previous slides there that I just showed, I suppose I highlighted the importance for us as a national clinical team in terms of creating a shared vision and buy-in. Can you tell us a little bit, I suppose, about how you did that at a local level on the ground?
Yeah, so the integrated care model was a very new concept to many, and the challenge really was selling the idea of what integrated care meant. So emphasising that chronic disease management service was a wraparound service for GPs, that we weren't trying to create another hospital in the community, but trying to shift left and prevent people from being admitted to the hospital. So the key elements really were the local governance groups, which were set up. They helped us roll out pathways between the acute and community, bringing together the key stakeholders. Thankfully, we had a really good working relationship with Tala University Hospital staff as they really bought into the model. Service user engagement helped us to shape our services further. And then hub services were promoted by the staff via webinars, videos, and actually in our link there, you'll be able to have a look at some of those. Podcasts, posters, grand rounds over in the hospital, conferences, social media. And this really helped not only attract new staff to the hub, but also to spread the word to the public and acute and community partners. So I really had to sell the vision to anyone that I met. As staff were onboarded and services were really started to take shape, we spread the word to GPs and hospital staff, and referrals were initially taken from existing hospital waiting lists, but once HealthLink was set up and running, GPs were able to refer directly to the hub.
Great. So as you mentioned there, you had some videos, so we'll actually put the link into the chat there so people can actually watch some of those, and I definitely think they're worth a look. Gillian, can you share some learning with us about, I suppose, what worked particularly well that others might benefit from, your experience and knowledge around that?
Yeah, I suppose a large amount of the success of the model was based on building good relationships with all of the key stakeholders. So, for example, with the acute staff, building relations and pathways between the hospital and community services. Being closely located to the hospital was really helpful for us. We were literally at the gates of the hospital, and joint meetings across sites, having consultants working across both the hospital and the community area, and providing governance was hugely beneficial. We worked closely with all of our community colleagues, and we were working really towards a common goal. GPs, we tried to really buy in and build their trust, because I know GPs in the past may have experienced where services were set up, but then only to find that if somebody left, they will be pulled. So it was really to try and sell the fact that this model is here to stay and it is sustainable. The service user, we obviously wanted to make sure that, and again, there was always a little bit of hesitance with people wanting to attend the hospital as opposed to community. So really to build their trust and to let them know that the quality of care was there available in the community for them. So really it's a shift in mindset, keeping the patient at the centre of the care delivery and asking, what does the patient really want?
So I suppose, Gillian, while it sounds like that things have gone along very smoothly there, I imagine that they haven't been without their challenges. So can you just share with us again, I suppose, how you've worked to overcome some of the challenges you've encountered in achieving the success that you have in the Tala Hub?
Yeah, so the model was being rolled out while we were still recruiting. So it was challenging managing expectations in a constantly evolving service. Staffing was not, unfortunately, equal across all of the hubs within the same CHO. And of course, this would have caused then friction or frustration, I suppose, between GPs and staff alike. So keeping everyone on board, working towards a shared vision was really key. I'm hoping that the RHA structure will help balance this out, and we need to look at innovative ways to integrate, for example, in-reach, outreach services between the hospital and community, joint student placements to help plant the seeds for future integrated posts.
Great.
I suppose, again, one of the biggest challenges that we had was the IT system and the lack of an IHI number. So this delayed progress while we did find, trying to roll out systems, but we did find workarounds, and but still does remain quite challenging.
Okay, so Gillian, some really nice insights there and learning, I suppose, and innovation of how you've managed to implement the change and overcome some of the challenges. So thank you very much for your insights there.
Thanks, Maria.
And we might move to you now and maybe get some insight from you in terms of how you've operationalized the integrated cardiology services there in Wexford. So do you want to tell us a little bit about your experience of the service that you're implementing?
Yeah, thanks, Maria. So I'm Liz. I am the Integrated Community Cardiac Rehab Coordinator and the Cardiology CNS in the Wexford Chronic Disease Hub, and we're based in Enniscorthy. So I've been in post since April 2023, along with the Integrated Consultant Cardiologist and one other CNS, cardiovascular CNS, and a OP lead at that point. So we had 3 of the 7 allocated model of care cardiology staff in the hub at that point. And the good thing, I suppose, is that all 3 of us had worked in Wexford General Hospital, which is our affiliated hospital. And it was very evident from the very beginning that we all shared the passion, determination to implement the integrated cardiovascular service into the community. However, it was a massive change for us, developing and delivering a new service in an unfamiliar environment, I suppose. And we realized that working in the hospital was by no means easy, but it was easier to work there with the convenience of ease of access to most of the requirements for a service to be developed. But we focused on what we could do and didn't get too caught up on what we couldn't. But for us, having worked in the hospital with those long established professional relationships was hugely significant to set up. And we depended a lot on their goodwill from them to get us going in the very beginning. And then we were there for a couple of months, the 3 of us, prior to actually moving to the community. So we'd sown some seeds on what it might look like when we got out here.
So it sounds like existing relationships there were a very big key to success for you. But I suppose just in terms of how would you advise others who were maybe at further back the line in terms of trying to set up the cardiology integrated service, what would be your advice to them in terms of implementation?
Well, you need to allow time for this. You can't rush it at all. We agreed in our phase 1 of the rollout that we would include a direct referral for GPs to the cardiovascular service in the community. Now, none of us had any experience of developing a service in this close collaboration with our GP colleagues. So our initial interactions with them, they were quite cynical, and they saw it as another HSE service and another referral form that potentially wouldn't continue. But we recognise we had a lot of work to do to convince and demonstrate our commitment to the service delivery. So we reached out to one of our GP leads who had a very keen interest in cardiology, and he is a well respected and trusted amongst his GP cohort in the county. So we invited him to assist us with the development of the service, and his knowledge and his shared vision was absolute key to each stage of the success of our rollout.
So again, I suppose local GP and local engagement seems to have been a really critical success factor there for you. But again, I suppose like I said to Gillian, while it sounds like everything has gone on really well, it probably hasn't been without its challenges, Liz. So can you tell us maybe a little bit about some of the challenges you've been faced with and how you've overcome them or innovated around them?
Well, we've had a number of challenges, but probably one of our most major one, I suppose, was that our operational lead left the team not a couple of months after we'd started and hasn't actually been replaced. So the lack of this key role not being replaced has added a significant burden to us as clinicians in negotiating that operational development alongside our clinical workload. And at that point, the service was really gaining that referral momentum. But we remain committed to the service. We had to prioritise what time we were going to spend on what interventions that were going to have the most impact on the delivery of care to the patient. So like negotiating that community T-Pro for that communication piece, extra clinical space as the clinicians expanded in the cardiology team. And we sought and received support from the national team and the ICP, CD, and reached out to our colleagues locally as well in the acute services and networks and heads of disciplines. So without them, I don't think we'd be at this point, to be honest.
Okay, so it sounds like, you know, there's been a lot of engagement with different colleagues. I suppose, can you just tell us a little bit about the broader engagement with key stakeholders there around Wexford in terms of implementing the service and what the approach you took to that?
Yes, Maria. So in February this year, we thought it was an opportunity to bring our stakeholders together. We'd organise a community cardiology open day and have a public launch of the service, I suppose. So not only cardiology, but all our respiratory and diabetes colleagues as well. So we invited from acute, general practice, community and members of the public as well. And on the day, we had a number of posters displaying, which included feedback from our service user evaluation, service data and future plans. We were also invited to be interviewed on the local radio station, which was another opportunity to highlight not only the integrated cardiology services, but also emphasising the ambitious road ahead of the shift of management of chronic disease and providing that care closer to home for them. And the day was hugely successful and all our key stakeholders were well represented with lots of time for integration and networking. And really, I think it put the Chronic Disease Hub on the map in Wexford for us.
So some really positive communications and engagement there, Liz, and some really positive feedback as well, which is really, really good. And I suppose, Liz, can you just tell us specifically maybe about how you've operationalized your cardiac rehab service? Because again, cardiac rehab in the community is a new service. So it would be just interesting to hear some of your learning and insights there.
Yeah, Maria, as the year progressed, thankfully our integrated cardiology clinical team did expand, and we were then in a position to stand up the integrated community cardiac rehab service in the hub. And really it is an expansion of the Wexford General Hospital cardiac rehab programme. Our integration and collaboration are already, our professional relationship with them was really valuable, has been completely invaluable really to the success of this service development. And another key success, I suppose, is that the integrated consultant provides clinical governance for both teams, which is hugely important. And actually, Maria, we just last month we performed an evaluation of the participants that attend our programme here in Enniscorthy. And one of the main questions that we asked was, if the service had not been available in Enniscorthy, would you have been willing or able to travel elsewhere to participate? And with the results of 60% respondents stating that it would not have attended. So again, there's further evidence of the importance of a community specialist services closer to home.
So Liz, it sounds like the integrated cardiology service there has gone from strength to strength over the last 18 months. So congratulations to everybody there. So I think just, I suppose, to round off the conversation here today, I think it would be really interesting just, I suppose, to get one key message from both Gillian and yourself, Liz, in terms of what you would like to say to the audience to support them in terms of implementing integrated care. So maybe as we finished with you, Liz, we'll start with you. What would be your one key message to everybody?
Well, I think this is definitely a marathon. It's not a sprint, and you have to really take your time to plan things. We need to celebrate the wins, definitely, and working as a team is really, really important. Embrace the change and just keep focused on what the vision is.
Thanks, Liz. And Gillian, I suppose your words of wisdom to everybody.
Yeah, I suppose what I'd say really to everybody, Maria, is that perfection can sometimes be the enemy of progress. So really just, obviously not everything is perfect, but through innovation, through creative thinking, through collaborative working, you can achieve great things.
Thanks, Gillian. And I suppose just from the Integrated Care Programme for Chronic Disease, I suppose what we'd like to say to people is that while we've been here and supporting along the way, providing clinical guidance and support, we will continue to be available to people and would like to continue to work with everybody in terms of implementing integrated care for chronic disease, and that we really look forward to continuing to work with everybody in terms of implementing this person-centred approach and supporting services to flex to meet the needs of patients with multimorbidity and complex chronic disease, and really working in, I suppose, in a multidisciplinary and a multi-speciality approach and supporting that across the teams. So thanks very much to everybody, and hopefully you found the presentation and the conversation this afternoon useful.
Thanks very much to Maria, Gillian and Liz for a fascinating insight into working across hospital and community, and maybe also a glimpse of the future nature of care as our population ages. And it's really been very, I think, insightful to see the way in which you're working across those environments. hopefully in the future, the structure with the regional executive officers and joined up regional structures can support and assist some of the work you're doing. I'm very interested in the closing messages around persistence, teamwork, vision, and progress. I think perfection being the enemy of the good is a point well made. So now I'd like to introduce Katrina Heslin to talk about balancing stability with change. Thank you, Katrina.
Great. Hello, and lovely to be joining you all this afternoon for this webinar. And thanks, Liam, for the introduction. And a very special thanks to Maria, to Gillian, and to Liz for sharing their very real insights into change as they introduced and progressed the Integrated Care Programme for Chronic Disease. So just to move on to my presentation now, which I'm going to cover over the next 10 minutes or so. And to be honest, in listening to Maria and colleagues, I think what I'll be doing really is reinforcing and maybe summarising some of the key messages that they shared with us in terms of their real experiences of delivering change at the front line. So the focus is on balancing stability with change as we, I suppose, move forward with our whole focus on integration within the context of the health region reforms. So there's no doubt within health and social care, change is very present. It's constant in our environment all the time. And change in health and social care, as we know, can be very complex. And therefore, at times of change, things can feel quite uncertain for us. Things can feel as if they're being quite disrupted. And I know when Tony spoke earlier, at the moment, we're trying to minimize as much disruption as possible, but at the same time, there will be disruption. So it can feel quite messy. And I think when things are feeling somewhat uncertain or feeling messy, it really is important that we place a strong emphasis on creating a sense of stability for services, particularly as we're now going to be navigating this transition to new structures. But much more importantly, in line with much of what Gillian and Liz described in their real work experiences, we're going to be moving towards new ways of working and different ways of delivering services through pathways of care. So that can be quite, I suppose, a real opportunity for people, but it can also be quite an anxious time for people wondering how is that going to work. But we do know, and it was really, really evident from Liz and Gillian as Maria interviewed them there now, the real importance of local teams and how important local teams are in creating that sense of stability, particularly because they know what's going to work, and they know what's going to work, whether it's in Wexford or in Tallaght or in whatever other part of the country. Local context is key, and that's really, really important. And it was also very evident that people needed to understand what was changing and why it was changing, and that can be really important as well in motivating people around change. So sorry, just moving on to the next one. So how can we focus on stability? We do know that people do their best work at work when their environment is predictable. And also when people feel that the efforts that they're making, the additional work that they're going to is apparent to them, but that it's valued and that people can see that it's meaningful and that it's recognized as something really important. It's also important that people have a sense of control over their immediate surroundings, because certainly when things feel out of control, it can be quite difficult to engage in change processes, but also that people are part of very stable relationships. So what was really striking from Maria and colleagues' presentation was the importance of relationships, of teams, of connecting out with local communities, linking in with GPs, and that sense of stability around the people you know and the people you work with can help create that sense of stability, but also that real sense of connection to place. So I think it was Liz who described that public meeting that they held in Enniscorthy, and people really locate, I suppose, associate and see value, and when something is delivered locally, that really means so important to people. And in addition to that, some of the rituals we create at work, so be that some of our team meetings or the different learning opportunities that the ladies described, can also help create a sense of stability for teams and services when they're going through a lot of change. But it's difficult to create that sense of predictability when so much is changing, but it places an additional, I suppose, emphasis for all of us on creating the conditions for change and trying to focus on what will help with stability for teams. So because our system is really complex, and you could see that Maria referred to this in her presentation, sometimes it's helpful in complex systems to think in terms of simple rules. And we have, I suppose, presented 3 simple rules that I think were really evident in the presentations you've just listened to. And the first one being the real importance of that shared sense of purpose, shared vision. And again, both Gillian and Liz consistently came back to that. If people are clear about what the vision for the change is and the purpose of the change, it helps to unite people around something that's really meaningful, really important. So I suppose we can't overemphasize the importance of shared purpose and shared vision, keeping that within our sights at all times. And indeed, focused on the relationships, the teams, the people we work with. Change can only happen with people, and through the networks that we create. So as we move towards health region reform, we're placing a very strong emphasis on networks of care, on trying to create more networked services, similar to the Integrated Care Programme for Chronic Disease. That's all about networking, connections, creating pathways, and that's dependent on the people and that you work with and forming those really strong relationships at local level. But also knowing what an appropriate intervention might be to help support the change, because what might work in Donegal may not be sufficient or might need a different approach in Kerry or indeed in Wexford. So we do need to consider what an appropriate intervention might be to help support the change. So the message is very strong today, the need to focus on local teams, because teams are a source of stability. And all of us who work in teams, it's important that we understand what's expected of us. So what's my individual contribution to the bigger picture? But I think as we move towards more integrated working, we also have an additional responsibility, not just for our own individual accountabilities, but also to work and operate in a more collective way. So to think in terms of team, to think in terms of multidisciplinary. You could tell from the presentations earlier, there was quite a strong emphasis on roles now that may be crossing different boundaries. People working with GPs, working in primary care, working in community services, or in acute hospital services, or indeed with voluntary partner organisations. It's a different way of working, it's different relationships, and you're crossing multiple boundaries. So that takes an additional effort, and it requires people to support each other when that work is happening, because it can be quite challenging. So helping people to connect with wherever they are in the system. So that might be your community healthcare networks, some of the specialist teams that were described earlier. That sense of identity is really important, and that sense of belonging. So as we're going through the changes we're all embracing over the next months and indeed years ahead, it's important to have some sense of, well, what's going to remain constant, because that does help reassure people that not everything is changing. And also supporting people to realise how they'll continue to add value. There was a real sense from Maria, Gillian and Liz of the added value they were bringing to the people that they work with and the patient service users and others that engage with their services. And there was a real sense that they were adding real value. So knowing what part of the jigsaw you're bringing to the table and how you're going to help to knit it all together. And again, important that we're really upfront about what is going to change. And as Tony earlier, when he introduced the webinar, talked about, look, we really have to be upfront and communicate the reality of what's happening. So for us, it's important that we continue to encourage conversations with teams at local level on how they can contribute to the change. It was striking for Maria, she said how I suppose her approach went from maybe being somewhat virtual and connecting with people through maybe different methods to actually going around the country and meeting with people face to face, and that was tremendously valuable. So again, very striking, a strong message, let's get the whole system in the room. And I thought again that was evident from the presentations earlier. It's challenging. It takes a lot more effort to get people together face to face. We rely very heavily on virtual methods of connecting, but there's a really strong added bonus when people are together. People are going to be coming from different perspectives, different cultural backgrounds, different cultural perspectives on things, but it's better if people are together to try and problem solve and see things from other people's perspective, to try and find solutions to common challenges and make sense of what might work and what might work in a local context. So I think getting the whole system in the room and more face-to-face engagement. And I know that's something that Tony and the regional executive officers, his colleagues around the country, are really keen to pursue over the weeks and months ahead. So when we think of maybe some appropriate interventions, and people listening to the webinar today are probably, I suppose, thinking in terms of how can you in your role progress integration. It's not something new. We've been really working hard over many, many years to deliver more integrated services. So I think it's about building on some of the successes that you've had and thinking about developments that will work within the context of your service or your team. I think it is very important, though, also to have a good understanding of what's needed to deliver integrated services. And I think that was the real value in the work that Maria described. And I think it might have been Gillian or Liz who described it was really helpful to have almost like a roadmap. So the work that was done nationally helped people and services locally to figure out, well, what are all the different elements of the chronic disease programme that need to come together? So it's helpful to have that support, whether it's through models of care or clinical care programmes, to know what are the different factors that are needed to develop more integrated services. And I think if we continue to keep the focus on the better outcomes for service users, families, and local communities, that will keep us on the right track. And it also challenges us. I heard the ladies describe how they had to flex, that piece about having to be more adaptable. Our operating environment is changing and we are going to be working in more integrated ways. So we do need to adapt and change that new environment. And the ask of all of us is a much more collaborative approach. I think that was really evident from the presentations earlier. So it's very much about aligning our efforts. So it's probably less about single disciplines, single services. It's multiple disciplines, multiple I suppose, multidisciplinary working, but also that cross-boundary working that we talked about earlier. That's really, really important in bringing those efforts together. Easier said than done, but much better achieved when people can do it through the relationships they've formed locally and through more and more engagement and face-to-face contacts. So within all of that, people are impacted. So we still have to think, well, what's the impact for the individuals and the teams that are going to be impacted by the change? And that's really, really important when thinking about change. So just to focus a little bit on that as we kind of come to the end of this part of the webinar, I suppose all change is about transitions. It's changing, it's learning, it's moving, it's changing to new ways of maybe behaving, new ways of working. And I suppose it's important to think, well, what's going to help people and individuals with that change? Because not everybody is going to think that it's a good idea and not everybody might be quite ready for it. So certainly some pointers here that might be helpful. It's really important that people understand the rationale for the change, the why. So if we're working and moving towards a more population health model, it was evident, for example, Maria described earlier about the changing needs of our population. So the change in profile of chronic disease in the community, understanding why we need to deliver services differently to meet that need is what will motivate staff and teams to come together around that shared purpose. So being really clear on the rationale is so important. I think the next point is also very relevant because I think the relevance of change becomes more apparent when I realize it's going to impact on me. So as personal relevance increases, my level of interest in the change also increases. So I think that's something just to be, I suppose, aware of. Some people may feel, well, the health region reforms, it may not impact on me. I think it will impact on all of us. We all have to work and behave differently. We all have a responsibility to think, how can we deliver better, more integrated services closer to local communities? So it will have an impact on me and it will have an impact on my role. So it becomes more relevant then to me in that context. And putting yourself in the shoes of that other person is always a good way of thinking, what's the impact? How must they feel? What's it, are they wondering what's this going to mean, or how are they going to have to maybe learn new practices or take on board new roles or expand their brief or work in a different environment that they never worked in before? That can be quite challenging. Some may feel it's quite challenging to work in an acute hospital setting for people who never worked there, or those in acutes moving out to work in community could be quite different. But many of those shared roles that Marie and colleagues referenced earlier will help to navigate some of that cross-service working. And again, keeping the focus on the opportunities that change can bring, but being really upfront. And I thought that was very evident from Gillian and Liz. They were honest in terms of some of the real challenges that people face, some of those ICT challenges, or indeed other elements that might need to be embraced to bring about the change. So keeping that focus on improved outcomes can certainly really, really assist. So finally, just a few things to cover, which I think were certainly picked up by Maria, Gillian and Liz earlier. And indeed, I think Tony certainly referenced it as well. Change is ever present in our environment, and within health and social care, we are constantly having to adapt to emerging issues that present to us. So that level of flexibility and being able to adapt to sometimes to the unpredictable is something we all have experience of. And I suppose we need to build on that strength of flexibility that we have. It does challenge us also, of course, to balance the day-to-day needs with implementing change. Referrals are still going to come in, reports still have to be submitted. There's always going to be KPIs that have to be met. There's new demands that maybe we hadn't thought of before. So you're having to manage your day-to-day services and implement the change. So I suppose I would challenge people to think, how can they embed the change as part of what they do, because change is ever present. It's better than to see it as an add-on that somebody else is going to do or an added burden. It's how can we embed it as part of how we approach our work, because change is all about learning, it's all about adapting, it's all about trying out things and doing them differently. It certainly was reinforced for me that from listening to Gillian and Liz, the importance of building on the experiences locally of what's working well, and building on those successes, and I suppose taking into account what the learning is in terms of what will work in a particular context. And again, I thought the concept of not waiting for perfection, because we are in a design phase in relation to the health regions, and we're going to be designing new clinical care or networks of care, or maybe slightly different ways of delivering our services. But we may not get to the point where the design is perfect. We need to take the risk, we need to take our agency and sometimes test out those designs, see how they work in practice, share the learning and adapt based on that learning. And I think that's an important message for all of us. So again, just to say, look, keep focused on that shared purpose. That's a really strong message from today's webinar. And keep engaging. So building those relationships, that's going to be the core to everything we do in embracing the change that's ahead for all of us within the context of the opportunities of the health regions, and indeed moving towards a more population health way of service delivery into the future. Important factor for creating stability during times of disruption. So we'd really like you to think about that. The link for responding to that poll will be shared with you, and we will discuss the findings from that result later on in our question and answer session. So thank you so much to everybody for having the opportunity to share some insights with you. But as I said, for me, really, it was reinforcing some of the key learning from people who have operational and real life experience of implementing change. So thank you for that opportunity. It was a privilege, certainly, to hear from colleagues earlier. Thank you.
Thank you, Katrina, and thanks to all the contributors. I thought a very interesting presentation. We've, just by way of introduction to this phase of the webinar, the slides will be shared, as was noted in the chat, by link afterward. And if there are questions that go unanswered, we can follow up on those. We have details to come back. But maybe first, there were some questions submitted in advance of today. There was an invitation to do that. And then some questions coming up on the screen, many of which have been answered directly, but I thought it might be useful to go back to Gillian or Liz and ask about, a question came up was, what's a typical day in a hub like? Is there, and there was an answer to that, and there are links on the ECC hub and indeed HSE land that demonstrate that, but I thought it might be useful for people on the call to hear that, if Gillian or Liz can speak to that.
Yeah, Liam, I can give you an overview, a snapshot of a day in the life of a hub. I mean, I suppose we have the three teams up and running, which is fantastic here in Tallaght. And say, for example, one of our outpatients would be an MDT outpatients, where it's for diabetes. So we have a one-stop shop where the service user will come in, they'll see the consultant, they'll see the podiatrist, the dietitian, the nurse, all in the one day. So the amount of time that is saved for a patient in that is just amazing, that they come in, continuity of care, care. Everything is discussed on the one day, and they go home with their advice. And so that's just one out of a number of different services. We have pulmonary rehab, we have group education for diabetes, we have our heart efficiency team, we have our respiratory outpatients. So within the hub, I suppose we are branched. We have an enhanced hub, so we're in Boot Road, and then we're also at the gates of the hospital. We're at Russell Centre in Tala. So loads and loads of activity going on. I mean, I suppose from an activity point of view, it's really amazing. From an operational point of view, it's challenging because you're trying to navigate lots of areas that you don't have the tools to do. So it's a constant challenge and sort of thinking outside the box and working around issues. But overall, it's a hugely positive feedback we're getting from patients is amazing. I could go on and on, but I better not hog.
Yeah, no, it's just interesting. I think it's just interesting for people on the call to hear that, Gillian. Thanks very much for sharing it. And there were a couple of questions, Tony, in the text in advance around reporting relationships of head of service and say GMs and reporting in where their relationships will be from next Tuesday, the 1st of October. Do you want to comment on that?
Yeah, sure. Thanks, Liam. So, yeah, I think first of all it's important that we'd be very clear that the period we're talking about is an interim period from the 1st of October to the 3rd of March, and we're creating that period to allow us to have further engagement and discussion with all staff, including heads of services and other stakeholders, about what the future and final management structure for the health services would be. But in that period, and in keeping with the title of the webinar as well, it's really important that services are kept safe, that service users and patients are kept safe throughout that period. So what we try to do is to move forward with the changes that are necessary, but do it in a way that tries to protect that basic principle. So directly to the question that you asked me then. So heads of service will have, we're just finalising a plan today, which will result in a letter going to each individual head of service, identifying to them who they will be reporting to administratively from the 1st of October. And administratively is important because we all need to have a line manager, but it's also not as important as the working relationships. And so we'll also be identifying in that correspondence that each head of service will be working with a number of IHA managers, and in some cases that'll be just one IHA manager, but in lots of cases it will be two, and in some cases it will be three IHA managers. So it's not ideal. It is an arrangement for the interim period, and it is manageable, but it's manageable as long as we all kind of stay focused on that basic principle. We're here to keep patients safe and keep services running.
Yeah, thank you, Tony. And there was a question which I'll take myself on, our Section 38 and 39 agencies involved and engaged, and the answer to that is yes, and they've been very much involved and contributing very positively into this phase of design that we're in, and will continue to be so as we move from now through to the 3rd of March next. And of course, in the current example, Tala is a Section 38 hospital working with community services. So, I think that's a very interesting thing to observe. Tony, just in terms of the regulators, HICWA and Mental Health Commission, are they aware of the changes that are coming and any impacts on them, or how has that gone?
Yeah, so well, I've had direct personal contact with them myself this week on Monday, but the reason I did was because we just needed to be sure that, we'll say, for really important services like our older people services, residential services for people with disabilities, or mental health services, all of whom are regulated, we need to be very clear with them about the various roles that people are fulfilling. So anyway, long story short, we've had contact and communication with them over the summer. I had a very direct discussion with both HICWA and with the Mental Health Commission on this Monday, just to make sure that we were all clear on that, and we are. The changes that we're making on the 1st of October won't impact on our registration for any of those services, but we need to keep them updated, particularly with whatever the final state would be on the 3rd of March. They'll be very interested in that.
Thanks, Tony. Maria, can I just ask you, in terms of the lived experience of the programme, have there been any changes to the way you're thinking in design terms around the programme based on what the experience has been?
I suppose what we've applied that constant change process over the whole period of engagement, really, Liam, to be honest. So I suppose when we initially started out, we started doing virtual engagements. The learning there was to go face to face, and we did that, and we just spent went on the road and did a road show in terms of that. I think, we moved them back to kind of more virtual engagement as well. And I think that's been really important in terms of establishing the relationships. I think kind of going forward, learning from kind of where we are now and obviously looking at the change agenda, we do need to rethink it again. And I suppose, one of the things we'd like to do is get feedback from our operational leads and from the teams around the country in terms of what's worked well for them. And we are engaged in a process of, I suppose, co-designing that with people at the moment. So again, I suppose it's been an ever evolving process. It hasn't been that we decided at the start that was how we were going to do things. We've tried to adapt to meet people's needs as we've gone along, and I suppose we'll continue to do so as the change progresses. And I suppose always aimed at trying to create the stability that we require from the areas to implement the model.
Yeah, thank you, Maria. And Katrina, just to go back to you, the resources available for people engaging in this kind of change. I know some of the links are going up, I think, in the chat or around the webinar, but is there anything you'd say to staff who may be listening or to people looking at changes like this in terms of the resources they can draw from that are kind of available within the HSE?
Yeah, so within the HSE and in the context the work we've done around the Health Services Change Guide, and we have a whole range of resources available, and they're available online, and those links, as I said, will be shared. And we've been adapting those to make sure that they're particularly relevant in the context of the health regions. So looking particularly at conditions for change and also at what are the key elements that will support integration. So we also have, I suppose, different interactive opportunities available for people. So we run change guide in action sessions, we run change consultation clinics. So there's different ways people can engage with us if they need practical help, or they need, I suppose, really a sounding board to tease out what might assist them. And I know that worked particularly well with Maria and colleagues to be able to link in, and it's just really good to see their work in practice and how it's translating. So certainly those resources are, and it's not just from ourselves across change, obviously colleagues in quality and patient safety, excellent resources there, and they're available locally too, because this is very much around I suppose, improvements to services, adapting services to local needs. And in addition, people who work in programme management offices who will be forming part of change and innovation hubs in the context of the new health regions are also a locally based resource that really understand the local context and can provide excellent supports for people. So we just, I suppose, advise and guide people to reach out for help, and we'll respond as best we can regionally or indeed at a national level to do what we can to support teams with change.
Okay, thanks very much, Katrina. And there are a couple of questions coming up around vacancies, and I think there was an observation during the presentation actually that the teams weren't all filled, and how's that working out? I don't intend to pass that to anyone, but obviously there's an impact if there are vacancies in a team or the team itself is still building. There was one specific question, I think, around the vacancies the 2004 vacant post was the question. So from our point of view, I'm not directly operationally involved in that, but I think some of that is obviously tied into paying numbers and maybe even into estimates 25 and the service plan for 25, which is just around the corner at this stage, given that the budget is just in front of us. Tony, there was another question that came in online prior to the call, which was around care networks. And I think as OREOs, you've taken a view to particularly explore older persons and women and infants care networks as exemplars at a wider level. Can you say a bit more about that?
I'm sorry, Liam, I just got a bit of interference as you were asking the question. Yeah. Do you mind repeating it?
Not at all. In terms of care networks, I think you were looking particularly at as a group of OREOs, looking at older persons and women and infants care as exemplars of care networks, and maybe working with clinical colleagues on that and operationally across the country. Do you want to say a bit more about how, because that will obviously assist in informing how we choose structures that make sense in the medium and longer term in the environment. Is there anything you want to add to that?
Yeah, so there are a few things that I'd say. One of them is that, first of all, we do plan on having networks of care, and we've identified 8 or 9 areas that we think would be appropriate. And they do include women and children. So they include disability services, of course. They include mental health. They include cancer services, and people will be familiar with I think all of those networks in different ways. But our plan is that we would kind of work that through over the next 5 months and design how that would look in each of the 6 regions. It may not be the exact, it may not be exactly the same in each of the regions, because, you know, if you take one like my own, where we've got mainly statutory hospitals and probably a well-established clinical directorate networks already in place, you know, I think that might be slightly different from the East Coast, where we've got large voluntary hospitals and a different clinical directorate structure. But it is an opportunity within the services generally, first of all, to drive standards and quality of care for sure, and I think we've seen experiences of that across the country. It's a way of ensuring that clinicians are directly involved in key decision making around the type of care that we provide. And I think one of the other things that it creates for us is an opportunity to knit our regions together, you know. So if you take my patch, we're going to have 4 IHAs, 4 integrated health areas, and the risk would be that that they would, you know, start to become 4 separate areas. Now, I certainly hope that won't happen, but I think one of the ways of ensuring that it doesn't happen is the networks of care, which will be across the whole region and will help to tie things together. So I think there's quite a lot for patients within that that construct, and it will definitely be a challenge for managers, because we'll have to manage it in a matrix way, which is always tricky. But actually, it's a headache I think that's worth having.
Yeah, thanks, Tony. And just to clarify, Tony, there was a query on the publication of the names of the integrated health area managers, which I think is happening over the next day or two, as I understand. Yeah. Okay.
Yeah. One of the unfortunate realities of where we're at right now is that we haven't had as much time as maybe we would have liked, or maybe as we would have had in other changes, to be able to communicate out to people who the key players are, who the new managers are, what the new locations are, and so on. And that's, you know, that's just a fact of life, unfortunately, for where we're at. But it means that over the next couple of days, just in advance of the 1st of October, that we will be communicating that out to staff and letting everybody know. Hopefully, over the next phase, we'll have a bit more time on our hands to be a bit more effective and timely in our communication. That just wasn't the way things were this last while.
Yeah, thanks, Tony. And I think it has to be recognised that you're building a team collectively at Oriels that is gradually coming in place around you, and your capacity hopefully will grow as those teams come into place. So thank you for that. Katrina, I think you have the results of the poll there if you want to.
Yeah, so I think just a little bit of assistance, the results are going to come up now, I think, Dan. So the question was, what do you think are some of the most important factors for creating stability during times of disruption or change? So that was the question that was posed. Now, I think the response is going to come up. Am I right? I don't see it just yet.
Hope so, anyway.
Yeah. I wasn't able to access it, so just a little glitch for me. I couldn't access it, but Dana Marie said she'd share it with us. So if she's able to share it, that'd be great. And if not, we'll have to share it afterwards. Yeah, it's just the question is coming up again, but I don't just see the answer.
Yeah, no, just
okay.
For people tuning in, Katrina, the panelists weren't able to answer the question, and maybe we can't see the answer either.
Okay.
Just maybe one last point, which has come up as a question: health and social care professionals and their engagement, involvement, and representation in the leadership structures. So the CEO has asked the Orioles, working with Colm Henry, Chief Clinical Officer, to look at that as part of this next stage of deliberation. I know that's been an issue. I'm just acknowledging there's a question there, and that the CEO has asked that question would be addressed within the next phase. So thank you for that. I think it just falls to me to conclude and thank the contributors. I thought it was a really insightful presentation, and thank you again to Maria, Gillian, and Liz, and indeed Tony and Katrina. I hope you've enjoyed the webinar. There will be a further webinars in this series, and we'll notify those. Thanks to everyone involved in the organising, and we'll conclude there. So thank you very much.
Thanks, Liam.
Thanks very much. Thank you.